Welcome to the conference session titled, What is PNH? Thank you for joining us. My name is Lee Clark, patient educator, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation using the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text window, and when you have finished typing, just hit enter. We will do our best to get to everyone's questions today. When asking questions, I do ask that you do two things to help me manage the incoming questions. Submit your entire question all at the same time, and please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. During this session, we have opened a few polling questions for the audience to respond in real time. To take the survey, please open the survey icon in the panel on your right, and you can answer any questions that you feel comfortable. Today's specialist is Lawrence Rice. Dr. Rice is a professor of medicine at Houston Methodist. He completed an internal medicine internship, residency, and hematology fellowship at Baylor College of Medicine. Dr. Rice was appointed to the faculty and became a professor of medicine and professor of thrombosis research. For more than 20 years, he served as the hematology program director and director of the required medical student hematology oncology course. He has maintained an active hematology practice at Houston Methodist for more than 30 years. With that said, it's my pleasure to welcome Dr. Rice. And Dr. Rice, you can go ahead and share your screen when you're ready.
Okay, can everybody see that now?
We see you, and you'll just need to share over.
Okay, I'm hitting share screen. Does that not work? Can you see the screen now?
No, not yet, Dr. Rice.
I wonder why not. Still not?
No, can you because you got to share from your desktop. Here we go. There you go, Dr. Rice. Thank you so much.
Okay.
We see everything fine.
Okay, well, I'm happy to be with you this morning. We're going to talk about everything you ever wanted to know about PNH. A couple of comments. One is that I'm indebted to Dr. Brodsky at Johns Hopkins for loaning me especially a couple of the more recent slides about new medications. And if certain questions come up that I might have some inside information about, I would have to decline to answer those, but I'm not sure there'll be much of a problem there. I wanted to start by telling you about a longtime patient of mine, and I'm certainly not telling you any confidential information. This woman has been all over the country telling people her story, but 25 years old, and she was referred to a hematologist because of anemia. And she gave a 3-year history of episodic dark reddish urine. She would have these episodes about every 2 months. They would last hours to days. Usually they would occur in the morning and then clear during the day. And I'll jump ahead just a minute. Needless to say, every urologist in town had done a cystoscopy on her, none of which were warranted. She also developed problems with swallowing at times, with chest pain, and she couldn't even hold water down. This was very distressing, sometimes lasted hours, and she suffered profound fatigue. So she had numerous evaluations over about 2 or 3 years, numerous ineffective treatments. She was anemic. Her white count was a little bit low. Platelets were actually normal. Her red cells were bigger than usual. But finally, she found the right hematologist, and he did some tests, and he did something called a Ham's acidified serum test. He did something called a sucrose hemolysis test. I'm not going to go into those at all. Those are now obsolete. We have better tests to diagnose PNH, but back when those were what we had, they actually worked pretty well. So it was established that she had paroxysmal nocturnal hemoglobinuria. This occurred in 1976. She is running around. She runs around more than I do now, and maybe I'll tell you more about that. So this is what her doctors told her. You have paroxysmal nocturnal hemoglobinuria, and from now on, we will call it PNH. So she's had PNH for more than 45 years. And when flow cytometry became available, this is the diagnostic test we now use, she was found to have a large clone size, 80%. Unlike some people with PNH, we have repeatedly checked her clone over decades, and it has never changed. She's always about 80%. Over the years, she used to receive prednisone treatments when she would have a flare in her symptoms. Um, Her hemoglobin would vary from mild anemia to severe anemia. And 15 years ago, she had a blood clot. She had a blood clot in her lungs, was started on blood thinners. It was actually at that time that she first came under my care. It was also at that time that she first required a blood cell transfusion. Um, in 2006, she had an especially severe crisis, required hospitalization, required multiple transfusions, developed renal failure. But with supportive care and fluids, she rapidly improved. The last time she ever received a blood transfusion was in 2009. By the way, by 2009, we had a new effective therapy for PNH that I'll come to. But she said, I've had this for decades. I don't need your new therapy. That's what she said in 2009. But in 2011, when her kidney function was worsening, she was convinced to go ahead and begin eculizumab C5 inhibitor therapy. This improved her situation. In fact, it improved her anemia. She felt much better. She now goes around the country encouraging people to take eculizumab, and she is doing great after more than 45 years. What is PNH? PNH is an acquired stem cell mutation in hematopoietic blood precursor cells, and it affects something called the PIGA gene that is on the X chromosome. And most estimates say that about 1,500, most estimates are closer to 5,000 people in the United States have PNH, about 5 per million. And it's a classic study where more people study it than actually have it. And with good reason, because we've learned so much from studying PNH, and what we've learned has been applicable to other more common diseases. And time permitting, maybe we'll go into that a little bit. But it illustrates how scientific insights from very rare disorders can lead to breakthroughs in more common problems. PNH can occur at any age. I have people in their 80s. There are children with PNH, but the most common age at which PNH first occurs is around age 30 or early 30s, and it leads to diminished quality of life and shortens the duration of life. But that these things have been changing with a plethora of new therapies that have come out and are coming out. PNH causes chronic intravascular hemolysis. We'll talk about that. And probably the most feared complication of PNH is that it can cause blood clots, both in the arteries or veins, some of which can be devastating. Used to occur in close to 40% of patients, has been the main thing that can shorten the life expectancy of the PNH patient. Again, these are all themes that we're going to be coming back to in the next several minutes. So what is this all about? Well, the gene defect in PNH leads to the inability to make something called a GPI anchor, glycophosphoinositol anchor. And it turns out that there are about 36 proteins in the body that are tethered to the membrane of various cells, including red blood cells, white blood cells. These proteins are important for the function of the cell, and they're attached to the cell by these anchors. And in PNH, you can't make the anchor, so about 36 proteins become lost from the blood cells. So this defect occurs mainly in blood cells. We'll come back to that in a second. And even though there are 36 proteins that are lost, really there are mainly two that have been found to be important. So just very briefly, because many people are confused about this, when you inherit from your mom or your dad a gene mutation, so this black little dot is a gene mutation, either the sperm or the egg has the abnormal gene, you inherit it, all the cells in your body then have that gene, and this would be a hereditary gene mutation. But this is not what happens in PNH. In PNH, the genes from your mom and dad are normal. The genes in most of your cells are normal, but it's in a stem cell for blood cells that this mutation occurs. And this leads to this abnormality occurring just in the blood cells. So this is in no way inherited from your parents. It's no way inherited to your children. So this is an acquired somatic stem cell mutation. It turns out that all of us occasionally get mutations of the PIGA gene in our stem cells, in our blood stem cells. Um, and we will come to that more in a second. And as we've said, 36 molecules are lost from the red cell membrane. But it turns out that probably the most important one in terms of PNH is something called CD59. It's also called membrane inhibitor of reactive lysis. And this is a protein that protects cells from being destroyed by a protein, by a cascade of proteins in the blood called complement. Complement proteins are important for fighting infection, but if they become too active, they can destroy your own cells. And CD59 helps protect your normal cells from the action of complement. CD55 is another complement inhibitor that becomes lost in PNH. Well, I just said that everybody gets these mutated cells now and then. How come in people with PNH, these mutated cells take over the bone marrow? Well, um, it has to do with it turns out that the PNH cells do not grow better than normal cells. They grow less well than normal cells. But people can develop problems such as an autoimmune attack on their normal stem cells. This is something that happens in aplastic anemia and in to some extent in myelodysplastic syndromes. The normal cells become attacked, but the PNH cells are able to survive the attack better than the normal cells. So the PNH cells are allowed to populate the bone marrow and become a substantial number of the bone marrow cells. So you have normal hematopoietic stem cells, the precursor to your blood cells. You get this mutation in PIG-A. All of us get a few of these, but in most of us, these abnormal cells die out and the normal cells continue to proliferate. So here is a mutated cell among the normal cells. But then if there's an immunologic attack that destroys the normal cells, the PNH cells are able to take over and you have PNH. What does PNH have to do with aplastic anemia? Well, I've sort of told you that, but I'm going to repeat it in another way. And it turns out that many PNH patients have aplastic anemia or MDS or used to have aplastic anemia. In fact, about 30% of PNH patients have aplastic anemia, and some PNH patients develop it later. Um, Even patients with PNH who do not have full-blown aplastic anemia, many of them have mild or moderately low white blood cell counts or platelet counts. Therefore, it's whatever has impaired the normal stem cells that has allowed the PNH cells to proliferate. And the current recommendation is that all patients with aplastic anemia and certain patients with MDS, especially what we call hypocellular MDS, be tested for PNH. And probably not just once, but periodically, maybe yearly or every 2 years, because these patients are at risk for developing PNH, and early recognition can lead to better treatment to prevent complications. Um, I hope not to get too bogged down in the complement system, but it is important to know something about it. So complement are a series of proteins that are important as part of our innate immune system to protect us from various infections. And there's three different pathways by which complement can get activated, particularly relevant to PNH. Well, all of these are relative to PNH, but the alternative pathway is one that continually has low-level activation. And all three of these pathways meet at a protein called C3, the third component of complement. And I'll mention here, but we're going to come back to later, that in this alternative pathway, there are other proteins, one called factor D, one called factor B, that help control the formation of C3. And C3 leads to the activation of C5, and that starts a cascade of reactions that leads to something called the membrane attack complex, terminal complex of complement, membrane attack complex. And this complex, C5 to C9, can destroy cells, can destroy red blood cells. So again, in PNH, these anchors, oops, the, these anchors that hold CD59, a complement inhibitor, and CD55, another complement inhibitor, these anchors that hold these to the cell get lost. So there is no CD55 and 59 to protect the cell from complement. And this is a cartoon that shows these are the GPI anchors. They're holding CD59 to keep the attack complex from forming and to keep it in check. And if you lose those anchors, which you do in PNH, then it allows this attack complex to form. And what it does is actually pokes a hole in the red blood cell, and the red blood cell lyses, it falls apart, something we call intravascular hemolysis. This is just another picture of the same thing. The attack complex forms a hole in the cell, and the cell bursts, something called intravascular hemolysis. And this is actually a scanning electron micrograph of a red blood cell in a PNH patient. And you can see that all these holes have been poked into the surface, and it's not hard to imagine that this cell is not going to survive very long because all the contents inside the cell are going to come pouring out. So when complement gets activated, the red cells are destroyed, which leads to anemia, a decrease in the number of red cells. Hemoglobin inside the red cells gets released into the plasma. Hemoglobin binds an important substance in your blood called nitric oxide. And when the hemoglobin binds up the nitric oxide, this can cause spasm of the esophagus, which leads to chest pain, difficulty swallowing, can cause pain. This commonly causes erectile dysfunction. In fact, drugs like Viagra that are used for erectile dysfunction work by increasing nitric oxide availability. This can cause fatigue. And then the hemoglobin is cleared by the kidneys. So you get dark red urine, and also over time you get kidney damage. So central to the problems in PNH is this chronic hemolysis. Normal red cells are protected from complement, but without the protective molecules, complement activation is going to lead to intravascular hemolysis, which causes anemia and leads to all these complications that we see in PNH: blood clots, kidney problems, pulmonary hypertension, muscle problems and pain, abdominal pains, the dark urine, and tiredness. So if you suspect PNH, if you have reason to suspect PNH, how do we make the diagnosis? For many years, this has been done by a test called flow cytometry, where we look for certain molecules on the surface of blood cells. And we test granulocytes, which are neutrophils, and monocytes in the blood, and also the red blood cells. And we measure whether these anchored proteins like CD59, CD55, and others are present on the surface or are missing. And we also use a flare test, which doesn't look for these attached molecules. The flare test looks directly for the GPI anchors and sees whether they're present or whether the mutation has caused them to be absent. So in normal people, 100% of the blood cells would have CD59 and CD55 and would be positive for flare for GPI anchors. But in PNH, many of the cells will be missing these. And clone size, if 80% of your blood cells, of your neutrophils, your monocytes, if 80% of them are missing CD59 or missing the GPI anchors, we say you have a 80% clone size. Briefly, PNH has been classified. I'm not sure how well this projects, but classic or pure or hemolytic PNH is mostly what I've been talking about up to now, where the main problem is this hemolytic anemia. But one can also get PNH cells in the setting of another blood disorder, such as aplastic anemia. So people with aplastic anemia may not have full-blown PNH, but they may have a certain percentage of PNH cells. And then people talk about subclinical PNH in the setting of another bone marrow disorder, where there may be just a small number of PNH cells, but it still may have important implications. So anemia in general means decrease in red blood cell number. And people who are anemic commonly get tired, and they get tired very quickly if they try to exert themselves. And if they have heart problems or lung problems, anemia will make this worse. there are three ways that people can become anemic. The most common way is that the bone marrow doesn't make enough red cells. And this is what happens when people don't have enough iron, or they don't have enough B12, or if they have aplastic anemia, the bone marrow doesn't make enough red cells. But another way someone can become anemic is if they bleed. But PNH is what we call a hemolytic anemia. The bone marrow is making red cells just fine, but the red cells get destroyed after they lose the bone marrow. And there are about 100 different types of hemolytic anemia, including such things as sickle cell anemia. There's something called autoimmune hemolytic anemia, where you get antibodies on your red cells. I mention that because we're going to talk about something similar later that can occur in PNH, but PNH is a type of hemolytic anemia. And the initial evaluation of anybody with anemia is that you do a careful history, you examine them, and you look at your blood, the blood smear, and you do a reticulocyte count. Reticulocyte count measures the number of new red blood cells being made and coming out of the bone marrow. So if you have decreased red cell production, your reticulocyte count would be low. But if you have a hemolytic anemia, such as PNH, the reticulocyte count should be high. Um, and just for completeness, and many people with PNH have pancytopenia, and people wonder what that is. Well, this is a normal blood smear, and here's a pan cell. And in pancytopenia, you don't have these pan cells. So anyone who thinks I'm being serious, get over it. I mentioned that there are many types of hemolytic anemia. They can be hereditary, acquired. PNH is an acquired hemolytic anemia. This mutation develops in the red cell, the bone marrow cell precursors. Hemolytic anemias can be intravascular, where the blood cells fall apart right in the bloodstream. That's what happens in PNH. But they can be extravascular, where the red cells are damaged, and then cells eat the damaged red cells, but they don't fall apart right in the bloodstream. Intracorpuscular means that the problem is within the red cell membrane. That's what happens in PNH. Extracorpuscular means there's something outside the red cell that leads to it being destroyed. So PNH is an acquired intracorpuscular, intravascular form of hemolysis. There are some other tests. We talked about blood smear, reticulocytes. Bilirubin can cause your eyes to turn yellow. LDH is an enzyme in red blood cells. And in my opinion, it's not a very useful test in most hemolytic anemias, but it turns out it is a very useful test in PNH. It is a very good reflection of how much red cell destruction is going on. So many studies, we follow LDH levels to let us know how active the PNH is. And in intravascular hemolysis, again, the red blood cell falls apart. It releases hemoglobin. We talked about how that can bind nitric oxide. It can also get cleared by the kidney, leading to red urine, leading to kidney damage. It binds to something called haptoglobin, causing low haptoglobin levels if you measure them. And we mentioned, so we're coming back to the fact that an important effect of intravascular hemolysis is that free hemoglobin binds and reduces the availability of nitric oxide. And that has a lot of deleterious consequences, including the erectile dysfunction, pulmonary hypertension. People with low nitric oxide get very tired. So central to the symptoms and complications of PNH is the intravascular hemolysis. And we bring that up because if we could address the intravascular hemolysis, it ought to have beneficial impact on all of these things. 5,000 people in the US are thought to have PNH. Most often, these are young people. the quality of their life is impaired, and they can develop shortened lifespan, particularly from blood clots, which can occur or used to occur in almost half the patients. And we'll talk more about the blood clots in a minute. So uh, um, before you shudder and become apprehensive, this is very old data. We're going to show you new data in a little while. But this is a report from 1995 by Peter Hillman, where he looked at 80 patients with PNH who were diagnosed between 1940 and 1970. And this was their lifespan. So half of them died within 10 years. Whereas here's what normal people match for age. This was their survival. So this is a more recent study from France, actually. In this study, they tried to identify all patients with PNH in France over a very long period of time. And they found that things weren't quite this bad, but they weren't great. They found that the median survival was 23 years. And what I'm going to show you in a minute is that it's actually now much better than this. So it keeps getting better, better, and better. But there's no question that PNH can be a fatal disease and has been. And we're fortunate that we have new ways to address it and that things have improved fairly dramatically in the last 15 years or so. And just more from that French paper, they made an effort to identify every patient in France with PNH identified over a 55-year period. And actually, they did some fancy statistics. They went to every hospital in France looking to see if they had any PNH patients. And they believed that they had identified 90% of all PNH patients in France. They came up with 460 patients over 55 years, 113 of which had the classic pure hemolytic form of the PNH, and others had these subclinical or aplastic anemia associated PNH problems. And again, um, looking at people over this period of time, their median survival was 23 years. It was better in those people who had been diagnosed later. And I'm going to show you it's better still now. And the major cause of death in those people who died were blood clots. And I'm going to show you more what we're talking about when we say blood clots. I'm going to show you that in a minute. Uh, just to show that I'm up to date, this is a paper that came out last month. This is a paper that came out from Great Britain last month, showing that survival of PNH patients continues to improve. Um, this paper found 80% survival at 10 years. Thrombosis has occurred in up to 40% of PNH patients. In many patients, it could be the first sign of the disease. It's the leading cause of death in PNH, half or more of the deaths. Why they get blood clots, there's probably multiple mechanisms. We'll come back to that. So some of the blood clots are blood clots in the legs that can go to the lungs. This is what happened in the patient I told you about at the beginning. These are the type of blood clots that normal people can get when they have surgery or other risk factors. But um, a substantial number of the blood clots in PNH patients can be strokes or heart attacks. And then a lot of the blood clots that can occur in PNH patients are unusual ones. And particularly common has been blood clots in liver veins, and this can be fatal. This is called Budd-Chiari syndrome. In normal people, this is very rare, In PNH patients, this has not been rare at all. And another unusual blood clot is in the cerebral vein, so-called cerebral venous sinus thrombosis. This is the blood clot that has concerned people recently from the Johnson and Johnson and AstraZeneca COVID vaccines. But it's been known that people with PNH can get these type of blood clots. And in fact, if someone comes in with one of these cerebral venous blood clots and without a good reason, and usually there is not a good reason, all people with those kind of blood clots ought to be checked for PNH. Um, Eculizumab, as we're going to elaborate, was the first approved therapy for PNH. It was approved in 2007. And what it is an antibody against C5, the fifth component of complement, the first step in that formation of the membrane attack complex that causes the red cells to burst. And when they did the initial studies of eculizumab, the patients that they enrolled had had 34 blood clots prior to enrollment. And this just is a representation of what kind of blood clots they had. So 12 of them had had this Budd-Chiari syndrome, blood clots in the veins in their liver. 4 of them had blood clots in other veins from their bowel. 3 of them had had these cerebral venous blood clots that I mentioned. And then you can see blood clots in the legs, in the that go to the lungs, strokes, heart attacks. So all of these had occurred in these patients. And I don't want to go into great detail on the slide or go through these numbers, but what this shows, there are a number of hereditary disorders that can lead to blood clots. One is called antithrombin 3 deficiency, protein S, protein C deficiency. Factor V Leiden is very common in the general population, and these are thought to increase the risk of blood clots. But the point of this slide is that PNH increases the risk of blood clots much more so than these other traditional risk factors. So PNH creates an extreme risk for blood clots, which can be devastating or fatal. And why you get these blood clots, these actually are not even all the theories, but a number of things have been identified that are probably part of the problem. It's likely that it's multifactorial, that a lot of these different things contribute to the clotting. For example, impaired fibrinolysis. Fibrinolytic system helps break down blood clots as they form to keep you from develop excessive clotting. And there's actually another GPI anchored protein called UPAR, which is lost from cell membranes in PNH, might be part of the problem of the thrombosis. Are certain PNH patients more likely to get blood clots than others? So people who get frequent episodes of red urine have been found to be more likely to get the blood clots. And in fact, if you have a crisis, if you have an episode where you do get the red urine with or without abdominal pain, it's during that event that the blood clot is most likely to happen. People who have higher LDH levels, which is an index of how much hemolysis is going on, people with higher LDH levels have been found to have a much higher risk for getting these blood clots. People with higher clone sizes have a higher risk of getting blood clots. So the reason this is important, or one of the reasons, is that now that we have treatments for PNH, it's those people who are having episodes of red urine, who have very high LDH, who have the highest clone size. Those would be the most important ones to treat so as to prevent the blood clot from happening. People with PNH are very variable in what kind of symptoms they have. So almost all of them are anemic. Many of them have low white counts and platelet counts. Just about all of them have fatigue, often severe, profound, debilitating. Only a quarter or so report episodes of red urine. So if you're going to wait for someone to say, I have red urine in the morning, um, great, check them for PNH, but you're going to be missing a lot of PNH patients. So people with all of these types of problems, it may be a manifestation of their PNH, and you ought to think about that possibility. What did we do about PNH? Well, we gave them blood transfusions when they needed it. We gave them blood thinners when they had blood clots. It turns out that if you give people with PNH blood thinners and that's all you do, they actually don't work that well. Blood thinners don't work as well in PNH patients as they do in other patients. We give them things like vitamins. Some people with PNH lack iron, others don't, because you lose iron when you have the red urine. We used to give them prednisone. It was controversial how much good that did. It still is. We're not sure if prednisone is helpful or not, but we rarely use it anymore because we have better treatments. And bone marrow transplants is the only curative therapy that's known, but responses to bone marrow transplant have not been as good in PNH as certain other diseases. Now, when a PNH patient has fluoroaplastic anemia, that changes. Bone marrow transplant becomes a more important option. But with newer treatments, people with pure PNH rarely get referred for a bone marrow transplant. The transplant might be riskier than taking the available new treatments. So we're going to move to therapy, which um, probably many of the listeners wish we had moved to earlier. The first approved drug for PNH is called eculizumab. It's an antibody, it's also called Soliris, that blocks C5, which is the beginning of this terminal formation of this attack complex that causes holes to be poked in the red cell membrane and causes the intravascular hemolysis. So if you can block C5, you can prevent intravascular hemolysis. And we talked about how that's central to many of the complications. So let's see what happened when people were treated with eculizumab. Fancy slides. So in the trials that were done in the around 2005, here's the control group that was given sugar water. Their LDH levels were 2,000. Normal is about 200. And they stayed 2,000. If you gave them eculizumab, boom, they came right down to normal and stayed there. The group who got the sugar water, after 28 weeks or so, we gave them the eculizumab and boom, they went down to normal. So dramatic improvement in intravascular hemolysis as measured by LDH levels. Did these people need blood transfusions? Well, the people who got sugar water did, but the people who got the eculizumab did not need blood transfusions anymore. Did they get new blood clots? Almost never. Dramatic improvement in the rate of thrombosis. And this just shows that again. Before treatment, people were getting 6 blood clots per 100 years. Many were on anticoagulants, but once they started treatment, there were 2 blood clots that were seen. And if I remember right, they were minor blood clots. And many of these people were able to stop their blood thinners. And here is survival. Almost everybody survived, going out many years while on treatment. There's in not only my opinion, but almost every expert I know feels that ravulizumab is a new and improved version of eculizumab. So ravulizumab came on the market in 2018, and most experts consider this the standard of care for initial therapy of PNH. Again, second FDA-approved drug after eculizumab. It is similar to eculizumab. It's an antibody against the C5 molecule. It's chemically similar to eculizumab, but it has a much longer effect. So it only has to be given every 8 weeks. And the trials show it's at least as effective as eculizumab. And actually, um, not only do you not have to give it as often, only every 8 weeks, but the chance of having breakthrough. So even on treatment, people can occasionally develop a hemolytic episode, especially if they get an infection, which causes high complement activity. Um, these breakthrough events are much less common on ravulizumab than on eculizumab. So what do these C5 inhibitors do? They reduce intravascular hemolysis, they improve anemia so you don't need transfusions, they improve fatigue because you're not as anemic and because you're not binding nitric oxide. They markedly reduce the risk of blood clots, so they improve the quality of life and they improve survival. But some things they don't do. They don't affect the genetic defect or the clone size. They just keep the abnormal cells from hemolyzing. And if there are underlying aplastic problems, such as low white count or low platelet count, they're not expected to improve those. Um, are there side effects? The main one we worry about is meningococcal infections are especially more common and severe. Meningococcus is a relatively rare type, often serious type of infection, but it turns out complement is especially important in fighting it, and that's why everyone needs to be vaccinated. We recommend repeat vaccinations every 3 to 5 years if you're on a complement inhibitor. If you're on one of these drugs and someone were to stop it prematurely, it can lead to a hemolytic crisis for reasons I'm not going to go over right now. Um, we're going to talk about C3 mediated extravascular hemolysis. That can get worse. Generally, people need to be on indefinite therapy, and these are very expensive treatments. So, in PNH, if you don't have CD55 and 59, because the membrane attack complex forms C5 to C9, you get intravascular hemolysis. But if you block the C5 to C9, it turns out C3 can build up on the red blood cells, and you can get something called extravascular hemolysis. And to one degree or another, this extravascular hemolysis is extremely common in people on C5 inhibitors, but in most people, it's pretty mild, but in some people, it could be more severe. So people can remain anemic, um, and some of them continue to need blood transfusions. But I want to emphasize that the extravascular hemolysis is not as dangerous as the intravascular hemolysis. The risk of blood clots in people with extravascular hemolysis is much lower than the intravascular hemolysis. And some of the side effects like fatigue and muscle spasm and esophageal spasm are not seen with extravascular hemolysis, but it can be a problem. So people are looking at upstream complement inhibitors. Instead of inhibiting C5, which is what eculizumab and ravulizumab do, Why not inhibit C3? And therefore, you not only prevent the intravascular hemolysis, but you also can prevent the extravascular hemolysis. And we're going to talk in a second about pegcetacoplan, which is now FDA approved and on the market. And we're going to talk about a couple of drugs in development that target factor B, factor D, which also control C3. Pegcetacoplan was approved, and Palvally was approved for the treatment of PNH this year. It's a small molecule C3 inhibitor, and thus, as we said, inhibits both the intravascular hemolysis and the extravascular hemolysis. And this is some of the data from the trials. In this trial, people were on eculizumab, but they continued to be anemic because of extravascular hemolysis. So instead of their hemoglobin being normal, these people had hemoglobins of 7 or 8 or 9 or 10. And some of them had transfusions. So at this point in time, they were given pegcetacoplan on top of the eculizumab. And boom, their blood counts went up because the extravascular hemolysis was prevented. Pegcetacoplan can be used as an add-on to eculizumab, or it can be used alone, either instead of eculizumab as initial therapy, or if people are not doing well on the eculizumab, if they're having a lot of this extravascular hemolysis, it can be used instead of eculizumab. The eculizumab can be replaced by the pegcetacoplan. So some complement inhibitors for PNH. We talked about eculizumab C5 inhibitor. It's given intravenously every 2 weeks, on the market since 2007. Most experts don't use much eculizumab for PNH anymore. We prefer ravulizumab, which only has to be given every 8 weeks and has certain other advantages that we talked about. New agent now is this Empaveli, which inhibits C3. This is given subcutaneous infusion twice a week, approved this year. In development, in advanced trials, are these two agents which affect factor D and factor B. And these medications are pills, oral medications, not available, but perhaps will be in a year or two, more likely 2 or 3. Another drug in advanced clinical trials is another C5 inhibitor, which instead of being given IV is given sub-Q. A generic version of eculizumab is also in the works. Okay, so I'm coming to the end. I've been talking for almost 55 minutes, but we're going to open it up for questions. But I'm going to anticipate 3 questions because they're asked all the time. Can I stop my anticoagulant after I start eculizumab? So that's mildly controversial, but Dr. Brodsky at Johns Hopkins, who lent me the slide, and I agree with him, think most people who've had a blood clot with PNH and are now on eculizumab or ravulizumab or pegcetacoplan, most people can stop their anticoagulants. My woman that I presented to you at the beginning is now off anticoagulants, even though she had a blood clot in her lung years ago. I want to get pregnant, can I? Actually, it's interesting. Wendell Ross, who was a pioneer in our understanding of PNH, would tell his PNH patients, whatever you do not get pregnant. And pregnancy was an extremely dangerous time for people with PNH. Many of them got their first blood clot while they were pregnant. It turns out with eculizumab and new agents, uh, pregnancy is reasonably safe. And you can read the data if you'd like, but most people with PNH can get through pregnancy if they're on therapy. If someone with PNH is not on therapy and they get pregnant, they need to begin therapy immediately. Should I get the COVID vaccine? Well, the answer is yes, but there are reports that some people with PNH, when they got the COVID vaccine, developed a hemolytic episode, sometimes a severe hemolytic episode, sometimes even though they were on anti-complement therapy. So there are some precautions that ought to be taken. The main one is if you had your ravulizumab 7 or 8 weeks ago, that's not the time to get the vaccine. You ought to get the vaccine right after you've had your treatment so that your levels are high of your complement inhibitor. And you might ought to check in with your hematologist right before and more importantly, right after the vaccine to make sure things are okay and that we don't need to intervene to prevent other problems. You know what? I'm going to end with that slide. And thank you very much for your attention. And I'm happy to answer any questions.
Thank you so much, Dr. Rice. We do have some questions. Our first question is, why do some PNH patients have red or dark urine and others do not?
Um, there are a number of factors. So one is how much hemolysis there is. So in people with a lot of hemolysis, and usually they would have very high LDH, those are the people more likely to get red urine. But another factor is how much fluid you've been taking in, because if you drink lots and lots of water, your urine won't be as dark. And why is the urine often, not always, darker in the morning? So there's a list of possibilities. One is because you don't drink a lot of water at night. But some people have thought that maybe it's because you actually don't breathe as deeply at night and your blood becomes a little bit acid, and that can lead to a little bit more hemolysis. Many experts don't believe that. Some do. Another factor is it turns out your bowel gets more blood flow while you're asleep. And the bacteria in your bowel can activate complement, and there might be a tiny bit more hemolysis going on at night. So those are the explanations. Probably the most important thing is how much hemolysis there is and how much fluid you're drinking.
This question comes from a patient who has had moderate aplastic anemia for 10 years and was also diagnosed with a small 2% PNH clone. They'd like to know what is the significance of the clone. They also have had superficial blood clots in the lower legs and optic neuropathy. And they'd like to know, could this be due to PNH?
So that's a small clone. And a number of years ago, the answer to the question might have been a little different. But recent studies show that even people with small clones do have a small increased risk of blood clots. So the superficial phlebitis probably does have something to do with the PNH clone. The 2% clone, there's a lot of implications to that. One is it tells you that there is such a clone present, and it makes it more important to keep an eye on that, to recheck that periodically to make sure that's not getting bigger. No one would start treatment, would start C5 therapy, C3 therapy for such a small clone, but it is something that needs to be monitored. Another implication is, depending on how well or how poorly the aplastic anemia is doing, um, you say it's moderate, so apparently it's not that bad. But people who have PNH clones respond better to certain aplastic anemia treatments, to immunosuppressive therapies like ATG and cyclosporin, than people who don't have the clones. People who have the clones respond better to immunosuppressive therapies. So if that type of therapy became considered, the presence of a clone could bear on that.
Thank you. This question wants to know, how can a patient tell if they have extra or intravascular hemolysis?
Um, well, if you're having red urine and if tests show you have hemoglobin in your urine, that would always be intravascular hemolysis. But in other situations, you may not be able to tell yourself. You might have to rely on blood tests. So LDH levels go very high with intravascular hemolysis, but go up maybe a little bit with extravascular hemolysis. There are tests like plasma hemoglobin levels, which, if done accurately, go up with intravascular but not extravascular hemolysis. So um, you may not always be able to tell yourself, but blood tests would establish what type of hemolysis was occurring.
Thank you. This question comes from a patient, PNH patient, who is not having any symptoms. They like to know, what is the time frame symptoms or clone size can become a problem?
So it's very unpredictable. And I certainly have people with pretty large clone sizes who feel absolutely fine. I have one who runs marathons. He really does. And he works out in the gym and he's muscular. And well, let me tell you about him. Um, he felt fine and we didn't treat him. I said, we don't want to, but what happened to him is over time, he had 2 or 3 episodes of red urine where his LDH would go up. And I said, um, we're heading for a blood clot. We need to get you treated. And so he's now on treatment. But um, all people with PNH don't need treatment. There are some who don't. Um, with and symptoms are important. If you're not having symptoms, some people don't. Even if your clone size is high, you may not need to be treatment. Will you need treatment eventually? And I think most people with a large clone do. And what you see is you might see the kidney function starting to deteriorate. So sometimes that is what causes people to eventually get treatment. Um, it's just that everybody's different. Some of this is unpredictable. But if there are signs like um, episodes of red urine, episodes of very high LDH, then you need to get treated because you're heading for a bad outcome.
Thank you. And this question reads, when I started Soliris infusions, many of my wonky blood labs, most notably liver function labs, and very low platelets normalized within 2 weeks. Is there an easy explanation since this is separate from the protection from hemolysis?
Um, I don't have a good explanation. So um, a lot of people with PNH do have very low platelets, and it's because they have some degree of aplastic anemia too. And generally that doesn't improve or doesn't improve much with anti-C5 therapy. So if the platelets were very low and if they improved remarkably, good for you, but I don't have a good explanation. And generally liver test, I mean, I could make up some things. So maybe there were some blood clots in the liver and maybe they resolved. I'm um, I'm at a loss to give you a very good answer.
Thank you, Dr. Rice. And our next question comes from a patient who's currently using Ultramaris. They're having breakthrough hemolysis, and it's being suggested that they switch to pegcetacoplan. How does that switch occur?
Um, Usually, or at least what I would do, is add the well, first of all, I'd be interested to what the tests show. And it would be interesting, if not important, probably important, to see how much of this was intravascular and how much was extravascular. Coombs test could help there. But usually what I would do is add the pegcetacoplan to the eculizumab. And if that seems to be working well, one could slowly withdraw the eculizumab so that the treatment is only with one agent.
Great. Well, thank you so much, Dr. Rice, for sharing your time and your expertise with all of us today. If you would like to watch the session again at a later time, it will be available on the conference platform within the next hour by accessing the session and clicking on replay. Or you can watch through the on-demand tab in the platform hub. If you have any additional questions, you can send it to us in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. Please be sure to visit our exhibit hall. Our next session will start at 12:30. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we have done